she was too tired to cheat. And Dr. Patterson in leading the infection prevention program. And so I'm going to talk about seasonal versus H1N1 influenza, and it is a very timely discussion. It's all over the media now. We're setting tents up outside to have an influenza treatment clinic. So I think in that way it's a good topic to present. And I have updated the slides, but these are actually slides that Dr. Patterson put together for a pandemic influenza summit that she presented at and then shared them with me. And then things are happening so fast, I keep updating them with new information. So I think it'll be pretty to date. But if y'all don't mind, there's only 3 of you, so why don't y'all tell me who you are so I kind of know my audience, and I'll keep it a little informal.
Sandy Bell, I'm a geriatric psychiatry fellow.
Oh, cool.
Chico, yeah, dentist in geriatrics.
Good. So let me proceed with this topic and see what we can see. Now that's not working. There it goes. So the objectives, just briefly, so you'll know the direction I'm going to go, is to describe the epidemiology of the pandemic H1N1 influenza, to talk about the differences in risk groups for H1N1 and seasonal influenza, and really in your roles that's going to be very important because they are different. We're going to describe the treatment and prophylaxis guidelines. We're going to talk about the vaccine priority issues, primarily about H1N1. And then I wanted to discuss just major issues of influenza management that we've had experience. This year they're really different than some of the other years that we've worked with influenza. So there's 3 words that kind of float around that I wanted to talk about. One is seasonal influenza, and when we talk about seasonal, it's a contagious respiratory illness, and it's caused by influenza viruses that are circulating for the season, and they're predicted from the season before. So we call that seasonal influenza. It usually starts around October, begins to peak around January, February, and declines around April. Pandemic flu is what we use for the flu that we talk about as a global outbreak, and it spreads easily from person to person, and it is worldwide. It involves multiple countries across the world, thus being called a pandemic. And right now the novel H1N1 fits this description. Now it's interesting that a few years ago avian influenza was the scare, and it actually was enough of a scare that we have a pandemic influenza management plan that's been in place 4 years. Never had to use it to speak of until May. But it was the avian influenza that they felt like was going to migrate into humans and be human to human transmitted. But the interesting thing is it hasn't sustained that. We have some instances that are human to human in Asia, but just one case to one case, and it's not a sustained transmission. So influenza is thrown around a lot when we talk about, oh, I have the flu. But when we need to define it, what we talk about is that it's an acute respiratory illness with fever usually, affecting the nose, throat, bronchial tubes, and lungs. And I think one of the things they found out recently about this acute respiratory illness is they actually did autopsies on 22 people that died with pneumonias, and they found they were secondary pneumonias to influenza, and they never diagnosed influenza in the facility. So I think our sensitivity to screening for it, needs to move up a little bit higher than it has been, because what we're finding is it's the secondary, of course, pneumonias that frequently kill our patients, and sometimes the influenza we don't recognize as quickly as we should. Influenza is worldwide. We have both A and B strains, and it causes fever, myalgias, malaise, dry cough, coryza, sore throat, positive, and it sometimes has vomiting or diarrhea. The epidemiology is really important about influenza, because when we start trying to protect the workplace from influenza, we apply these criteria. So if you've been exposed to someone with influenza, it could take a range from 1 to 4 days for you to become symptomatic. And the part that really concerns us is that you begin to shed viruses 1 day before you become symptomatic. So it's really important that we teach people about exposures. For instance, if you have a child at home with influenza A and you've been caring for them, that's a pretty intense exposure. And what we've had happen here, and some of you may know these stories, is that we have had influenza A brought into the facility by a resident who had very sick children at home, didn't think he really had it, but had some symptoms, began to be sick. By that time he had exposed patients and staff, And some of those staff got ill. We treated the patients with oseltamivir, but some of the staff became ill. So we had actually kind of a clustering of influenza related to a resident working. And so we're always very concerned about that. And the problem is he was shedding viral before he became symptomatic. And so those cases, we don't really always know who those are. One of the issues with transmission, as you notice, I put contact and airborne droplet question mark. This slide, until this morning, showed droplet. And the reason that we're changing it and our practices are changing is that there are strong recommendations now from IOM and from CDC and public health for us to wear respirators as healthcare workers if we're working with somebody that has influenza-like symptoms at the bedside. So that kind of throws it into airborne. But I think the real issue with it is that the respirator fits you much better, so there's no possibility of droplets bypassing the mask, which sometimes is loose on the sides and not put on really well. But this is a huge difference. There's been lots of controversy over it, but all of the national guidelines now agree that with influenza-like illness, you should wear a respirator as a healthcare worker. So if you have a patient in the facility that you think has influenza-like illness, you should wear your N95. It's still hand-to-hand, so hand antisepsis is very important. We talk about it being droplet because it's spread by droplet nuclei, which is about 3 feet from a person, and this kind of just demonstrates how the droplets spread and disperse into the air. And then they drop, contaminating things around them, but then they live on surfaces for several days, so you can get it from surface spread as well. And that's why we call it contact now. And it can be generated in many ways. Coughing, talking, sneezing, close contact. And this y'all have probably seen before. It's just the cycle of transmission of the viruses, the HN viruses that cause influenza. And there's many different hosts. Ducks and waterfowl are hosts, and pigs and mammals. And so the transmission we're always concerned about is this transmission to the mammals and then to the humans. So the place where it becomes very, very concerning is if you get human-to-human transmission of one of these viruses that has not survived in humans before because we don't have an immunity against it. And this is just a picture of pandemic spread. This was back in August, so I'm sure this would look different now. But the main purpose of it is just to show you where the cases were. So back in August, we had a lot of cases in South America all the way up into Canada, and then we begin to see cases throughout Asia and Europe with a lot of patients in Indonesia. So that was back in August, and we have continued to see spread. At that time, there was over 200,000 cases worldwide and 2,000 deaths. This is a picture of, which is to date, of influenza positive test that CDC reports, and these are testings that are done through collaborating laboratories that sit in. And the main thing you need to see here is that the orange is 2009 H1N1, and the little blues are untypable ones. And so since about the May or so, we've been having an increase of H1N1. And this was our high spot was right here, but we were testing a lot more then too. Now we are not recommending testing unless the patient is hospitalized. And I'll talk about that in a few minutes. So this is probably an artifact of increase because now we're not testing as much, but it just shows you the percentage of H1N1, and that's why we talk about treating H1N1 rather than seasonal, because we're not seeing seasonal in our laboratories. So we've had about 4,000 cases reported. When CDC models, it estimates it to be about 1 million actual cases. There's been about 5,000 hospitalizations from those cases in the United States and about 300 deaths, which is less than 1% mortality. And the important thing to remember about that is seasonal flu has a mortality rate of less than 1%. So we're really not seeing an increased mortality rate yet with H1N1, although we are seeing increased deaths in pediatrics. And in Texas, we've had 28 deaths, and 18 of those have actually been pediatric deaths. And when you start talking about who's targeted for the vaccine, obviously the children are going to be targeted because they're getting very sick, and we're having a high rate of cases in children. So I'm going to go over for a couple of minutes just some data here from Audie Murphy. This is the lab testing data, and it's up to date through this week. And the orange is flu A, I'm sorry, the orange is, the bar is the total number of testing done, and the orange is positive flu A's, and this is negative flu A's. But if you remember in your readings that the rapid test has a susceptibility or a sensitivity of only about 10 to 70% with a mean around 40%. So even though we've tested a lot more, we've had a larger percentage of our total testing that's positive. We know that these could have been influenza-like illness and actually been flu A, H1N1, that didn't test positive, which has been kind of a little messy with the screening.
How would that not test positive? Because they're calling it H1N1 an influenza A type virus, right?
Right.
So is it not detecting H1N1 this test? Or like
the sensitivity of the test is not good. So, if you get a positive, it's reliable, it's a positive. But you have about 10 to 70% or, 10 to 70 out of 100 that could be positive that don't test positive. But if you send it for a PCR, it might be positive, right? And so because a test is not reliable, we're trying to move toward treating more influenza-like symptoms and looking at syndromes. And that's one of the reasons that we are also looking at what we call syndromic surveillance, which actually is done by the chief complaint field and also by ICD-9 codes. But the respiratory syndromes are the blue, and here is where we had that same little peak before, and then it kind of declined, and now week 37 was 2 weeks ago, and we had a peak, and last week it kind of plateaued a little bit here, so we'll see what it does this week. And then the other way that we look at it, besides chief complaints, is by the ICD-9 codes, and this blue line on this particular graph is 2008, and then the red line is 2009, and so we have a peak above the blue, which was seasonal last year, in the period of time that we're in now. And so those are some of the flags we look for as we begin to set up the flu treatment clinics. We're beginning to look at the increase and what is presenting itself into our epidemiology patterns. This was the week ending September the 19th, and it just basically shows that we have widespread influenza through much of the United States, including Texas. There's only a few states that have local spread, but all states have been affected. When you compare it to other pandemics, we always talk about the Spanish flu, 1918. That mortality rate was double what the mortality rate is now, is 2%. We had 500,000 plus deaths and 40 million deaths global. In 1957 and 58, the influenza caused 70,000 deaths with 1 to 2 million global. And in the 68-69, we had another pandemic that caused 36,000 deaths and 700,000 global. So really, this was the big guns here, and they kind of decreased. On novel H1N1 today, we've had over 300 deaths and 2,000 global deaths. And the point of that being, it's still young in our season. We're just now beginning to see this spike, so we don't really know how H1N1 will end up on mortality. This graph I put in, I think it's important because what it shows is the number of deaths in pediatrics. And that is one of the reasons they've become a high-risk group. But you can see here between week 23 and this is about 30, I guess, that we have quite a peak of deaths in pediatric patients. And so when they start looking at the epidemiology of who's dying from H1N1, they realize that our PD population is really our high risk, and they're obviously going to be number one on the criteria for getting H1N1, as well as people who take care of them at home or pregnant women. One of the things that's kind of been fascinating about pandemic flu is, I like the slide that Dr. Valdez did. It's called Predictably Unpredictable, because on the pre-April assumptions, this is really dealing with H1N1, H5N1, avian flu. And what we thought would happen with it, and all of our planning was directed with these principles in mind, and this is what reality happened. So we thought that we being, the experts of the world, thought that the pandemic strain would be avian. And it's not, it's actually H1N1. And we assumed there would be a very high mortality and morbidity rate with H5N1 because that's what we were seeing in the few people that were infected with it. And the reality is we have a very low mortality rate, less than 1% with the H1N1 novel. We thought the outbreak would start overseas, and it actually started in Mexico and migrated very quickly into Texas. And so we were kind of in the center of the discovery of the H1N1 pandemic and watched it spread from this central focal point out instead of Asia in. And so we had to react a lot more quickly, and that's where we had schools closing, if you remember. People were really frightened. They had heard, like in Mexico, that they had a high mortality rate. The children were getting very sick from it, and so we had schools closing. And now the TEA is not recommending schools close unless their absenteeism becomes so low that they need to close based on a rate. But and then the other thing is that we've been able to conduct surveillance for changes in the strains, and we did not think that we would be able to do that. And we didn't think we'd have vaccine available, and we do. Hopefully, in October, we'll be getting it. These are characteristics quickly of the symptoms reported in Texas, and fever has been reported in 94% of the cases. And on our screening, we use 100 degrees Fahrenheit for that break point, and then, of course, cough, sore throat, diarrhea, and vomiting. And I will tell you, yesterday on a conference call, they were saying that there had been a lot of children that actually had not ran high fevers, that had become very sick. So I don't know if that will be published after they review records or not, but fever has been important.
Like runny nose.
I don't know, was that on there? Let's look. It doesn't say that it was. HRSA is not on there. It's fever, cough, and sore throat primarily. And then here's just a comparison between Mexico and Texas, what our surveillance showed. And it was sort of similar in the less than 5 years of age. And then in the group 5 to 18 years, we had a much higher attack rate than they did in Mexico. But greater than 45 years, we've only had a 4% attack rate. So we really are not seeing people 65 and older as being high risk for H1N1 morbidity and mortality. A little bit on the diagnosis, I had mentioned this earlier, that the rapid diagnostic test is a very low sensitivity, and it varies depending on the season and the strain. So what we have gone to do and recommend right now is that if you have presentation of patients who have very mild symptoms, we would not do a rapid test. We might not even treat it with oseltamivir because there's some resistance developing to oseltamivir. So it would depend on the comorbidities of that patient and the risk of them, getting sick, particularly like if they have any kind of lung disease and then have influenza on top of that, or they're immunocompromised, that kind of thing. And that's really left up to the physician to make that decision about treatment at that point. But we really try to give them supportive care, stay home, social distancing, take some Motrin, Tylenol, whatever it is you take, drink fluids, rest, hand hygiene, cover your cough, all those real basic things. And then the oseltamivir is kind of dependent. But if we admit somebody to the hospital that has influenza-like symptoms, we will do a rapid test, and even if that rapid test is negative, we'll send it for PCR. And now we have PCR equipment at university, the Quest labs have PCR, and I believe Methodist has PCR, so it's available to us. Do you know what the cost of the test is? Have y'all heard what the PCR for influenza costs? It's $300 on an average. So that's one reason we're being a little bit more cautious about who we use it on. But if there's a cohort in the hospital where we have employees exposed or a very sick patient, we would send it regardless if the rapid test is positive or negative for a PCR. Of course, a DFA is very specific, but takes a longer than the PCR is a very timely test. Viral culture is a gold standard. It takes about 3 or 4 days at least to get those reports back, and then serologies we don't use because they're not efficient to use. So what do we do with a rapid A test? We can say if it's positive, they might have H1N1, they might have seasonal flu. It doesn't distinguish between the two. If you have a false positive, you might still have H1N1.
There's a seasonal H1N1 that's not the novel H1N1?
No, the seasonal is not, but it is positive by the test. The test is positive for any influenza A. Okay, it's not specific, or influenza B. It'll distinguish between A and B, but if it's positive for influenza A, we don't necessarily know that's H1N1. And in the spring, what happened is the public health system became a diagnostic system instead of epidemiological. So one of the things they learned is we can't do that because they were just inundated with tests because they could do the DFAs and PCRs, and they just were overwhelmed with testing. And so now what we're doing is doing less of it and treating if the person has influenza-like illness.
At this point, we're still a bit too early for seasonal influenza, right?
It hasn't been identified yet.
Okay.
Okay. We can have cases as early as October, but usually they kind of straggle in until January, February, and then peak. Most of the data shows the peak for Texas in February and March timeframe. But what we watch for is what public health tells us, because they have laboratories that participate and send in specimens that they test. And that's why they're called an epidemiological lab. They're just trying to let us know what is circulating in the community and how to treat it. And that becomes important because if you remember last year, we had been treating with oseltamivir seasonal, and all of a sudden we found out it was resistant and had to go back to amantadine, so influenza. So it does make a difference sometimes based on treatment. This is just an algorithm that's going to be used to interpret the test. If it's positive for flu B, we would treat it like it's flu B. If it's positive for flu A, then we really wouldn't know if it's H1N1 or H3N2 or something else, but we could treat with antiviral agents. And consider further diagnostic tests if the person was very, very ill or had a high severity of illness or had a lot of exposures. And then if it's negative, you can't interpret it for ruling out influenza virus infection, so you have to, again, just in summary, go back to the symptoms. So who do you treat? You treat uncomplicated febrile illness, mild symptoms. Therapy may not be required, and you have to use your clinical judgment on that based on your case presentation. You would treat hospitalized patients or those with severe illness and those at high risk for complications like pregnant women less than 5 years old, chronic underlying illness, immunocompromised, greater than 65 years old, and long-term residents. You know, it was funny, we have one of the infection preventionists is pregnant, and she was sick and was home, and she's never sick. And so I finally called her after she'd been home 3 or 4 days, and they had just put her on Tamiflu because they couldn't figure out what was wrong with her, because it's such a risk for a pregnant woman to have illness, and they hadn't tested her, and she really didn't have real strong symptoms. But I'm guessing that her physician knew the risks were so great to her and her baby that they put her on empirically. So I thought that was kind of an interesting story. We don't treat many pregnant women, so don't have much expertise in that area. This is showing how the children became an important group as high risk, and the elderly are not. Here's your 65 and plus group, and they have a very small attack rate, whereas as you go up, you see your children a much higher attack rate than the elderly. And they use this data to help us decide who's going to get the vaccine and in what order. And then if you look at antiviral resistance, it's important because we have seen some H1N1 resistance to oseltamivir. It's not been very great, but it has really slowed the prescribing of oseltamivir down for mild illness. So we do treat healthcare worker exposures with it because we want you to stay at work and stay healthy and be able to do your jobs. But this just shows you the resistance pattern, and seasonal H1N1 as of last year was resistant to oseltamivir. So it will be important as we get into seasonal influenza to distinguish between the two, which one the person has if they're very ill with it.
That would be the PCR.
Yes, ma'am. We'll send it for PCR. And then post-exposure chemoprophylaxis is simply us who work in the hospital can be exposed either to our coworkers or to patients, and we will treat people who have close contact with a case that's confirmed suspected or probable, and anyone with high risk of complications or healthcare workers. And you usually stay on 10 days, once a day dose.
I have a question. This may seem silly, but if we're only really testing people that are hospitalized, how can you really do post-exposure prophylaxis if you don't know it's a case or not? Like, for instance, my daughter just had 3 days of fever. For all I know, she had it. Should I be getting post-exposure prophylaxis?
Well, they have an algorithm. I don't think it's occupational health has an algorithm. I think it has not worked well, but what the algorithm says is that you could call occupational health and ask them for guidance. But the discussion is actually that you would be...
She got over it, she's fine, but I don't know if she had it. We didn't take her in. She wouldn't have probably received the treatment. She's fine. She's healthy.
Well, on the algorithm, the options are to wear a mask during direct care or to be considered for oseltamivir if you've had an exposure.
Okay.
And I will tell you, it's really been our house staff. I mean, they have been our high-risk group because you have children. I mean, those are the ones that we're seeing get sick at work and expose people and have to go home. So that's why I would recommend just talking to Dr. Pinter or Dr. Boyd about it and seeing what they recommend, because they're seeing more of the employees than I see. I don't see the staff, so I don't really have a good sense on it. But I do the cohort workups, and that takes a lot of energy and time. And the last one that we did was a resident, actually, a fellow that was in a pulmonary conference room, and we had a full room of people that could have been exposed, and so we tried to do the workup, and we still heard later that somebody was very sick that was in that room that we never found out about. So they did well and recovered and all, but it's hard to, they're difficult cohorts to do versus a TB cohort, for example, and do a really good job on it. So we're just trying to keep awareness up. What are some of those issues that are difficult with influenza? Well, we have this big controversy over, do we wear a respirator or a barrier mask? If you have a hospitalized patient, wear a respirator. They may or may not be in airborne precautions if we have a room available, but you'll wear a gown and glove in the room with a respirator. We think in the influenza clinic, because there's fairly good air circulation, and unless the patients are coughing a lot, they will wear a barrier mask because it's very hard to wear a respirator for a very long time. In any one given moment. And then we thought PAPRs were a little bit futuristic for our patient population. We have to do a lot of explaining why we were wearing PAPRs. They're purified air respirators, and they run on a battery charge, like Outbreak or any of those exciting movies we've seen. Yeah, so we decided not to do that. But I think that's one of the things that's been really challenging with influenza, is being fluid and changing as it increases or the symptoms increase, because it's very difficult right now to know how it compares to something like SARS, which was terrible what happened there and the people. And so we are much more cautious in what we do in prevention, because the strain could change, or it could reach a different intensity as we have more numbers. So the other thing is negative pressure rooms, and what we're doing right now, because we don't have a lot and we're not seeing a lot of morbidity and mortality, is we will use them if we have them. Antiviral treatment changes due to concern for resistance, so we're not treating with antivirals as liberally as we used to, even though we have lots of oseltamivir available. We have this influenza treatment clinic to try to segregate those people who may come into the hospital to any of their clinic appointments with influenza-like illness, to kind of hopefully slow down hallway transmission. We have to allocate who gets H1N1 and who gets seasonal, and seasonal is offered to anyone who wants it. We have plenty of it, and we, of course, in the state of Texas, don't mandate healthcare workers to take it. In New York, they do, so it's changing as we speak. But the allocation of the H1N1 I'm going to talk about a little bit, because it is very different than the seasonal, and we won't have enough to offer it to everybody. So let me go on for a minute. And then, of course, maintaining healthy employees. This is the special respiratory precaution sign that we're almost finished with. I think we have to put a hand sanitizer here instead of just hand washing. But what it says for influenza-like illness patients, visitors must report to the nursing station before entering. We have limited visitors and healthcare workers. Now, the reason we've done that and helped spread this word is not for any other reason except respirators are hard to get. And because it's special respiratory precautions, airborne contact, you can't reuse the respirator. With TB, we let you reuse the respirator. You can fold it and put it in your pocket for 8 hours. You can't do that with influenza. So we did put a thing on here to limit healthcare workers, so we don't have these big teams going into every room all the time and going through our respirators fairly rapidly. I think we figured out if we continued the same pace of care that we would on a normal basis, we would use about 50 respirators a day per patient. That's a lot of respirators. And that's, yeah, because you'd have to change it with each patient. So every time a nurse goes in the room, she has to take off her gown and gloves and her respirator and use hand sanitizer and then re-guard it again. So that's part of the problem. Gown, gloves, approved respirator. Face shield or goggles are also recommended, and this is our face shield that we've had to order and are trying to get available up in those PPE cabinets. We don't have a lot of goggles, but if you're doing any of these type of treatments, you know, the goggles are obviously preferred because they give you better eye protection than the face shields do. Now, we have had a discussion that's kind of interesting about the face shield. And this is how it goes. The face shield covers the respirator. So would that let us reuse the respirator? Because the droplets would be contaminating it. Well, that's true if we teach how to take the respirator off without contaminating it, which is very important. So right now, we aren't doing that because we're not using a lot. But if we had 6B as our influenza-like ward, we might decide we need to do that and look at trying to do that safely. But those are the kind of discussions that we have trying to figure out what's best. This was a picture Dr. Patterson put in from 1908. He just says, obey the law and wear the gauze, protect your jaws from septic paws. So it's just encouraging, you know, universal masking, which we haven't moved to yet, but is also discussed some days. So what can you do? Hand hygiene, you know, it's there. It's the best way to prevent transmission. Carry it in your pocket. Use it when you have a chance. Respiratory etiquette is a little newer on the scene, and I see people still having difficulty with it, but try to keep your hands away from your face. If you have to cough or sneeze, use your arm to stop the dispersion, or your jacket, so that your droplets don't disperse into the air and contaminate the environment, or your hands that you tend to shake with. And that's what we talk about when we talk about social distancing, thinking a little bit more in Texas about not shaking hands and not hugging, and maybe keeping a little more distance when you're working with people that have a potential of being ill. So it's kind of a different approach than I think we're used to. And the whole goal of that is maintaining the workforce. And here's some pictures of respiratory etiquette. And it's kind of interesting, they're targeting the children now. This is a new sign that came out. It usually was the adults, so that was a new sign. And then this is our sign downstairs. I think we're getting ready to change it because it's been out so long and the fever needs to be 100. But this was something we used in, I don't know, were y'all here in May when we had the active surveillance? This is a sign we used there. Signage becomes important. Okay, to conclude, I just want to go over the differences in the indications for flu. Seasonal influenza is all persons greater than 50 years old, and that's the high-risk group for influenza, is the people you work with. Children 6 to 18 months, of course, and persons 19 to 49 that are pregnant, chronic illness, or household contacts of high-risk groups, and then, of course, healthcare workers. Now look how it changes with CDC based on some of the graphs that I showed you and information that they collected. Pregnant women, the top #1 category. If you're pregnant, you should get the H1N1.
Will the VA have that?
Yes, yes, we will. Yes, and I'll tell you a little. I'll tell you, you'll be first in line. Caregivers of children less than 6 months, which could be some of you if you have children. Healthcare workers, particularly those in high-risk work doing direct care, and then it kind of goes down through the ages from there. Related to H1N1, we are going to get 43. Hang on a second, I have to say it right. 4,300 doses from CDC for employees, not veterans. The veterans H1N1 is going to come from the state stockpile. And I have no idea about that, and nobody wants to talk about it, but it must have been a negotiation about who rules. So we had to apply through the state registry for our vaccine, the H1N1, for veterans. But in October, hopefully the middle or toward the end, we will get 4,300 doses, and we have to decide how to allocate that. And of course, pregnant healthcare workers would be key on the list. Any pregnant person that works in the facility would be #1. But really all healthcare workers with direct patient care. So all of you will be on that list. And we're trying to decide right now how to distribute that, because veterans are already asking about it. How do I get my H1N1? And so there's some media that needs to be done to educate them. The thought is from CDC that there will be enough that everybody will get a vaccine, but they will not get theirs in the first group of vaccine we receive. So we're not sure when that will be. So that's a real concern of mine, because you know, we are here to serve the veterans, and we're going to do that by protecting ourselves from flu and not transmitting it to them, and staying healthy at the workplace so we can take care of them. But on the other hand, they're going to be wondering why they can't have it, because we are preaching to them, get your flu vaccine. And then the other thing they're talking a lot about is making sure the pneumococcal vaccine is updated because of the secondary pneumonias, and many of those have been caused by strep pneumoniae. So I think that is another thought with your population that you wouldn't want to.
Is the vaccine back down to a one-dose thing? Because I know at one point it was going to be a two-dose.
Right now it's 1 dose for everyone but children. I think children are going to be 2 doses, but we will get 1 dose as healthcare workers.
So, as I understand it, they're not recommending it for 65 and older period, even if they have chronic disease.
No, with chronic disease they would be like, but they're in a lower, they have 3 groups,
Oh,
3
I see,
priority
I
groups,
see.
so they're not a high
Because
priority
they
group.
pretty much all have chronic disease.
Yeah.
So, and like when you're saying the treatment with the Tamiflu, I'm like, that's anybody in our clinic.
Right.
That comes in with flu symptoms should get it, because they all have chronic disease.
Oh, well, I know. And it is tough. It is tough with that group. But they're really not seeing in the community population is not showing up very severely ill with influenza, which is the good thing, is that population you're working with, if they do get it, it's staying mild and not requiring a lot of treatment versus them getting pneumonia in the hospital. So that's all very, very
So
good.
For presumptive treatment, I don't need to send a swab unless I'm going to hospitalize first.
That's right.
Because we tried to send a swab last week and it was the wrong thing and the lab didn't take it anyway. So anyway,
Yeah,
but
you
now
really
I
don't.
even bother. with
Not
that.
unless you want to hospitalize them. And you can
Okay.
still treat with oseltamivir if you feel like that person's at risk for complications. So that's how the
I have
prescriptions
a couple questions about, it's like a two-part question about oseltamivir. Do you have any hints for people tolerating taking the Tamiflu? Is it like GI upset?
I
nausea?
don't.
And then is there any, if a patient just can't tolerate it and they need to stop the Tamiflu,
They could take Influenza. That would be.
but would you want them to finish a 10-day course of something? Or if they get,
Well, I think it
Or
depends
they
on
have
how
to
ill
do
they
it.
are. I mean, are
Okay.
they responding or
like
not?
for prophylaxis?
Well, they wouldn't need to take it. Like a healthcare worker would need to wear a barrier mask to take care of patients. But if it's somebody in the community that's exposed, I probably wouldn't even treat them, until they start to get symptomatic. I mean, we're trying to keep the healthcare workers at work. So if we get exposures and you want to take oseltamivir, it's ordered for you, and the Tamiflu is available
Right,
for
so,
you.
well,
But in the community, if it's an exposure, I probably wouldn't treat. I'm sorry.
I took it last week and I couldn't finish my course.
Oh, who you were talking about?
Yeah. Well, I was just saying, no, I was thinking that if I had problems with it, then if I gave it to someone, if it was for treatment, what do you do? I mean, like if they decide can't take it, I guess they just can't take it, but I was
What symptoms did you have? Did you?
My daughter was fairly ill, and then with me being with her and being a healthcare worker.
Right. But did you, when you took the oseltamivir, what were your side effects?
Vomiting.
Oh, pretty serious.
Both me and my husband.
And did you try different things like small meals or
I tried to eat it.
crackers?
I tried to take it right when I ate. I tried to wait until a few hours after I'd eaten.
That's interesting.
And we both had really.
I think that's a really good question, and I don't have an answer to it, except I do know that on the algorithm that it would be appropriate when you're working with.
You could switch them over if they were.
And you could put on a barrier mask at work until you're past that 7 days of risk.
Okay.
Pardon?
She was wondering
I'm
if she should
wondering
take
if I'm supposed to be taking it. Does your daughter have a confirmed case or no?
They wouldn't test her.
I know.
But she had like a fever 104.
Yeah, really ill. Yeah. And I will tell you, I don't talk about it as much as maybe I should in this group, but I really feel like the real key is hygiene, hand hygiene, respiratory etiquette, environmental cleanliness. Keeping things clean. Yeah. Social distancing, I think, helps. There was a graph I kind of went past that didn't show that, but this is an example of what social distancing is not. But I think I believe strongly, and I believe that it's evidence-based that those things are very, very helpful. And what's really wonderful, I've been in infection prevention for 15 years, so I started in a time when people didn't care about hand hygiene, and there's still a few people around, but now I'm seeing my daughter's children pop out their hand sanitizer. Or one day my husband offered me some. It was like, you know, so I see a real change in our culture, and I think those are real important changes and will really prevent our exposures. I think family's hard when you have children and they're ill. You're going to be there present with them and holding them and doing what you need to do to comfort them. You know, so that's a lot harder, but to come back to work, I mean, you have a choice. You could take a Tamiflu, or you could wear a barrier mask in case you begin to shed virus before you become symptomatic. That's why you would do that. But I don't have any other answers. I've never taken oseltamivir, and I haven't really talked to a lot of people that have become ill. I don't know how many people take it. We give it to a lot of people, but I actually have picked up the pattern of if they're not ill, they keep it until they get ill. So, you know, I didn't say that. Take them off. But you know, we did have that as an issue with some of our exposures that didn't take it. So, anyway. Do y'all have any other questions? Thank you for listening.
Do they know when the vaccine is available for kids yet? I mean, have you heard? I know
Well, the state,
you may not know what
the state is supposed to come in at about the same time we get ours, and that's in October. I don't know how much they're going to be dropping at one time in a shipment, but the doctors had to register. So what you should do is ask your pediatrician or your obstetrician, did they register to get H1N1? And if they didn't, then you'll have to find another place to get it, like here.
I have a question about that. There's all kinds of sort of concern over the safety of vaccine. And even my pediatrician said, well, we don't know. Well, first the front office told me they didn't order it and they didn't plan on offering it. And I was like, excuse me, can I talk to the physician? And then I talked to the physician and she says, well, we've ordered it, but we're not sure we're going to offer it because we're not sure about the safety. And then I heard from another physician, Dr. Horton, whose daughter goes to that one, that she kind of heard the real truth is they're not sure they're going to offer it because of the burden of giving it. It costs more for them to give it. So I don't know what so is there really real concern? From what I've heard, the safety is the same with the
It's the
flu
same
vaccine.
as with the seasonal.
So
The only thing that I heard
upsets
that
me.
kind of yesterday caught my attention was that it's going to be in multi-dose vials, and so it will have thermosol in it. And so I think that's really important for us to know. Well, it's mercury is what it is, but it's a very minuscule, you know, amount, and there's been no evidence that it really causes autism, for instance. Matter of fact, there's more evidence that it does not. But I know, like back last year, people were really questioning that about their children being vaccinated with anything because of that. The doses, like we have for seasonal, that are single dose, don't have thermosol in them.
Now, here's another question I actually thought of. If you believe your child may have had it, should you even bother with the vaccine if they've already been exposed and like basically were ill? I don't know.
Yeah, the recommendations is you should.
You should.
That's the
anyway.
recommendations.
Okay.
Yeah. Because, you know, they don't know. And I think those are really hard questions
There's
to
a lot of hard
answer.
questions.
Yeah.
But okay.
Because you know, you're making the decision to protect for today based on what you've been told through, you know, the experts, but you don't really know the outcomes later.
Right.
So, you know, it's not easy to make those decisions, I don't think.
The question about the vaccine, which may not maybe a dumb question, I know, but like my kids have their vaccine appointments next Friday, and they get the flu shot, seasonal flu, and whatever else they need. But if they have this swine flu one in at the same time, can you get both? And it wouldn't make a big deal,
Well,
or would it cost
yeah, they really recommend waiting 2 weeks after, and I think children particularly, they recommend waiting. You can give it together, but the recommendation is it's preferred if you wait. But like our veteran population, we can give it together. But I'm thinking you probably should check on that.
I don't think it will be available by
I'm
next
not sure if
week
it will be,
anyway.
Yeah, I don't think it will either, but I'm kind of thinking they may want you to wait. These are all great websites to go on, and those questions are there. You can get answers from them. I printed one out this morning over what to tell the person over 65 about H1N1, because it's a little different than seasonal, so there's many resources there.
I got an email yesterday that they don't have a flu hotline, it's 211.
Right.
Instead of dialing 911, you dial 211, and anybody can ask.
And it
I
works.
have a
Did you
recording
try?
or-
Did
I
you?
haven't tried
I
it
tried
yet,
it because I'm actually not at work this week, and I tried it. I tried it, and you get a person.
Do you?
Uh-huh.
I don't know.
But it,
Okay, this is another question. If someone has a febrile illness, is there a certain period you should wait to get any vaccine, like even the seasonal vaccine? Or
it is recommended, yeah.
it's like 5 days or something like that?
mhm,
Okay, I forgot about that.
Yeah. Or 24 hours after the fever is okay, but after 5 days is fine. I mean, but it's not because it gives you a virus. What it does is it challenges your...
Just allows you to kind of recover.
Yeah, because it challenges your
give
neurological
another
system. You're going to build
challenge.
antibodies,
Yeah.
so...
And then what was the incubation period again? I came in late, I'm sorry. For the
1 to 4
H1N1.
days.
1 to 4 days.
And you shed virus 1 day before you become symptomatic. So you really, the high risk period after exposure is about 4 days. Hey, thank you all so much for listening.
Y'all be sure to fill out your evaluations, turn those in on the table, please. Thank you all for coming. Thank you.
Oh,
You're welcome. Appreciate it. And you came in on your day off?
well, I had to go to school anyway.
Okay.
I'm working on my dissertation.